my name is Kate Hedlund. I'm with Cook County Health. Thank you for joining us tonight. If you need help with an appointment or have a medical question, you can reach our health system at 312-864-0200. Again, that's 312-864-0200. My guest tonight is Dr. Matthew Kaminsky, trauma surgeon at Cook County Health. Welcome to the show, Dr. Kaminsky.
Hi there.
Tell us a little bit about yourself.
I'm a trauma surgeon at the Cook County Hospital. Obviously, that entails a certain line of work in the community over here. I've been there for several years, since approximately 2012, after my trauma training. I like cars, I like sailing, and I have 2 kids that take up a lot of my time as well.
Great. And what interested you working in trauma, specifically at Cook County?
It's kind of one of those things where trauma surgery picked me more than I decided to become a trauma surgeon. Very early on in my surgery residency, we get to see a lot of different kinds of surgeries, and the acute nature, the adrenaline, the quick decisions picked me, and as I was essentially never happier than those nights where you'd have a bunch of cases, a lot of exciting things happening, good stories, unfortunate stories, all of which I found quite rewarding, and started a career path as such, and have never looked back.
So Cook County Health has the oldest comprehensive trauma unit in the country. Can you talk a little bit about the makeup, the amount of the staff you have, and what differs an emergency room versus trauma?
Very unique to the Cook County Trauma Unit. We were America's first organized trauma unit. Obviously, there were different setups in a lot of places with casualty areas, and trauma surgery and trauma is not new to America or the world. However, Cook County was the first to specifically organize it, record the data, and track the results, and to take any type of patient. If you were a trauma victim, they took ownership of that individual, as opposed to placing them with an orthopedic surgeon or with a general surgeon. They were taking all of the care of the patient, no matter what, and quarterbacking their care amongst the specialists that may or may not have been needed. Our staff right now involves 7 full-time trauma surgeons. We're a separate department in the hospital, which gives us our specific area and our ability to manage our administrative businesses and outreach, and a lot of the things that we enjoy doing as trauma surgeons. But a big part of the muscle and work is done by our trainees, our resident cohorts, which are sent to us from a variety of medical schools and universities in the Chicago area. And we also have trauma fellows, which are junior faculty members who spend the entire year with us. And they provide a lot of the muscle and the work that needs to be done, all while being rewarded with an exceptional learning environment.
Talk about what kind of patients do you see in the trauma unit?
We see all kinds of patients, frankly. Unfortunate, a large part of our patient population is from the needy areas of the city, areas that are marginalized and prone to violence. And unfortunately, that's a high burden or a disproportionate amount of African Americans, Hispanic, but trauma has no no racism or decisions, and so we have a lot of individuals that fall and hit their heads. We have people that are in car crashes, and those those kind of incidents do not discriminate rich or poor and whomever.
And how do you guys get involved? How do you work together with the emergency department?
They, again, unique to the Cook County Trauma Unit, we're a separate department and a separate area just beside the emergency room. And so the emergency room handles a lot of heart attacks, cough and colds, pneumonias, and medical, acute medical problems. In order to be admitted to the trauma side of things, you need to have fallen from a certain height, displayed certain physiologic changes that are very concerning for bleeding or for respiratory problems. And so we're separate from that. This allows us to focus only on trauma, and we don't have to be either being distracted by other things that are non-traumatic, and so we could focus a lot and organize our work around patients that are traumatized.
Can you talk about the research that Cook County Health does and why the health organization feels it's so important to invest in?
The Cook County Trauma Unit has a very extensive history and a long dedication towards research and promoting and elevating trauma care. And so there's a very rich history of publications on a variety of trauma fields from our trauma unit. Our department lead, as well as the hospital, has been very supportive and engaged in research, promoting, furthering, and keeping us at the leading edge of the sword of trauma care.
One of the big issues that Chicago faces is gun violence, and Cook County Health is working toward putting together this new trauma study. Can you talk about emergency preservation and resuscitation?
So this is, again, almost bordering on science fiction, but overall, trauma care has improved so much that people get to the hospital extremely quickly after their trauma. They get extremely fast operations, blood products, resuscitation, and interventions are essentially instantaneous. We're so good at it that essentially the next level of saving lives is either preventing the trauma from happening in the first place, which would be public policy or public interventions, which is a little bit outside of our surgical specialty. But in order to save the next couple percent, the studies that we are currently investigating and getting involved with involve essentially preserving the body as it's about or is threatened to die, and continuing the resuscitation in a preserved state, fixing the problem, and then reawakening the patient, or possibly reanimating the patient and waking them up again.
Can you explain how that process works from the time a patient is brought into you?
So the protocol or the idea is that as the heart of this patient who sustained a trauma is about to start or about to stop, catheters are placed into the heart and the major blood vessels, and a cold fluid is circulated into the body, and specifically to perfuse or to get the brain in a hypothermic state, still getting some nutrition, as well as doing the same for the heart. So if you have the central nervous system and the heart in a preserved or a state where it's still getting some oxygen and at a low metabolic rate, this allows us time to repair the bleeding blood vessel from somewhere else, or fixing that spleen, or doing the intervention to fix the patient. Once we have dealt with that, we would proceed with wakening the patient, warming them up, in order to get a neurologically awake person that's able to interact with a beating heart, and to proceed at that point.
So you're cooling the body down by pumping this water or this saline solution through the body, correct?
That is the goal, yes.
Okay. And what does that do to the brain and to the organs by doing that?
Many people have heard of people falling in cold rivers or lakes and having extended periods of times of underwater or in a hypoxic environment. The goal of getting the brain or tissues into a hypothermic state is that it greatly reduces the oxygen demand that tissue is requiring. This way, the tissue it's not frozen, but it's in a state where its metabolic rate is very slow. So whatever low oxygen state the tissues or body is in, it may be able to be preserved so that when it does warm up again, it's still functional, as opposed to being damaged from a hypoxic warm state, which is generally very bad.
And how does where did this study start from?
Again, it's borderline science fiction, but the goal is to save that next 1% to 2% of trauma victims. And it was out of studies in Pittsburgh, I believe, where they were trying to push the envelope and pushing the theory that people's brains and hearts are able to sustain a hypothermic state for a period of time while they fix the problem. There's some laboratory data and some animal data suggesting that, and some of the forward trauma units are looking at this in order to possibly save the next 1% to 2% of trauma victims.
How unique is this study?
We are the only center in Chicago considering and getting approval to do this study, and I believe there's only one or two other trauma centers in the nation that are looking to do this, and possibly I believe there's only a very small handful of patients that have gone through, but if you don't try to get this 1% to 2%, you'll never get it if you never try.
You touched on it a little bit, but can you talk about, when we're talking about hypothermia, normally especially when we're talking about this cold weather in Chicago right now, we talk about how bad it is for the body. Why in this case is it good? Although it's very cold outside and uncomfortable, that's your skin and outside part of your body that's feeling that's uncomfortable. Your brain and heart are highly metabolically active, especially when you're at body temperature where we are designed to operate at. Similar to when patients go for cardiac bypass surgery or other invasive surgeries, the heart may be placed and completely stopped with no blood flow, but it can survive a very long period of time if it's cooler. And this way the metabolism and the metabolic rate of the tissue is slower when it's cold. This way it's burning less oxygen, and so during that period of time it does not require any oxygen or very little oxygen,
So whatever blood that's in the tissue or any fluids that are around there with some oxygen, it's able to extract that and use it without choking itself or dying off due to lack of oxygen. And this is all because it's at a hypothermic state. Similarly, organ transplants, when they bring tissues from one body to another and transplant them, they're put at a cold state in order to preserve that tissue. They don't freeze it, but they do bring it to a cool state to reduce the metabolic activity.
What, what is kind of the issue with consent? I mean, is everybody who comes in the door who's been injured by a gunshot or something like that, a stabbing, are they going to immediately be put into this trial?
No. We anticipate registering or possibly enrolling very few patients in the study. In essence, everything has to be perfectly right for this to be possible. If you could imagine a terrible injury or multiple injuries that are non-survivable, and the patient has died, that would not be a good candidate for this study. We do have patients that come in with a low burden of gunshots or a particular area of the abdomen or limbs that have been injured to the point where they're peri-arresting or about to die. In those cases, we often have to open the chest to put a clamp on the aorta, and this allows blood flow to be maintained to the heart and to the brain. If that heart were to become very sick and to start to stop or look like it's about to stop, that patient may be a good candidate for this study. At that time, it's not possible to ask them if they'd like to enroll in a study. We generally assume that if there's a chance of being saved, most people would want to at least give it a shot. But we don't want to be looked at as experimenting on people. That would not be appropriate. And so the conditions and the injury burden has to be just right in order to be considered for this study.
And if somebody is listening tonight and knows that they would not want to be participating, they can pick up an opt-out bracelet, correct, at the trauma?
That's correct. We've done a lot of community outreach and engagement with the community to make sure that this is at least in line with the values of our community, and that this isn't us thinking that this is a fun thing to do. By all means, what we're looking at doing is how do we save that next 1% to 2%? We're pretty good at what we do, and our save rates are very good if you come into our trauma unit with a blood pressure and a heartbeat. You have a significant chance of surviving no matter what your injuries are. And we are looking to see how we can save the next few percentage points.
Your trauma team is very involved in discussing gun violence, and what do you see from your perspective, from a healthcare perspective, in the work that you guys are doing?
There's so many levels of how our work it involves the community. Obviously, there's the medical and surgical components. That's one part of the job, but the patients that come into our trauma unit essentially reflect what's going on in the community. And so by definition, it's a mirror into what's going on in a lot of the problem areas of the community. And that unfortunately involves a lot of gunshot wounds. It involves fights, disagreements, fires, and all kinds of things. So like we mentioned, how do we save the next couple percentage points in our trauma unit? It would be a lot better if we didn't have the problem in the first place. And that's a public health component to what some of the workers in our department do as a full-time job. They're engaging with the community, and of the survivors that we do have, they're automatically enrolled for support. It's well known that this is not the first time they've been traumatized. Their communities have seen violence. They've had family members injured, often to gun violence. So although it may be the first time they were shot or injured, they've seen these patterns before, either in their schools or in their community, definitely. And we have a lot of work to do in that area.
Shifting gears just real quickly with the cold weather, you guys will see a lot of people being brought in. What are some of the things that people should be cautious about in this kind of weather?
With the cold hitting, unfortunately, way too early this year, it does allow, unfortunately, some people may not have been quite prepared enough. We see a variety of injuries from the cold. As frostbite can, at these temperatures, can take a bite of your tissue pretty quickly, especially if you're not protected. So if you're going to be out in the cold, obviously warm hats and gloves and clothing, and especially if we can anticipate that. People should look for, or if you know of people that need a place to sleep, warming centers, and to make sure that people aren't spending the night exposed to the cold. And those individuals occasionally come in the next morning with severe frostbite, which happens in these temperatures. The other component from the cold side, a lot of people have heaters in their houses that are possibly unsafe and should be monitored. And people with diabetes or peripheral vascular disease, or may not have good sensation of your hands or feet, occasionally they'll put them on radiators or warm or heat sources, and they can't quite feel like normal. As such, they actually get a severe burn without realizing it. And so there's the frostbite component of the cold, and then the burns that we see.
Okay.
Mm-hmm.
And you've mentioned you've been a trauma surgeon for a while. At the end of the day, what keeps you coming back every day?
It's an exciting job. You might call most trauma surgeons adrenaline junkies, but there's a significant unknown when a very sick patient comes in that you have to diagnose, treat, and deal with very quickly. Not everyone enjoys that type of work, but for those who do, you get quite satisfied, and it's extremely rewarding to take a patient from the brink of death to bring them back, and then see them walk out of here, and you've met their parents, their siblings, their community, and you've essentially become one with that family. And you see them down the road 3 months, 6 months, years down the road. The people that have had a lot of injuries survive and are doing very well, and they visit us again. And you have a good time laughing and chit-chatting on how they got close to leaving this world and how we got to know each other. And you become one with these families and these patients.
Sure. Well, thank you for the work you do. As a reminder, if you need an appointment or to talk with a physician, call our number at 312-864-0200. Dr. Kaminsky, thank you so much for being here with us tonight, and thank you for the excellent work that you do every day.